Hey everyone, welcome to my Day in the Life series here on White Coats and Corgis. Most of you probably know me from Instagram or TikTok, where I make helpful free content for pre-meds and talk about my journey as a first-generation medical student. My mission here on YouTube is to give pre-med students all the information they need for a career in medicine. So in order to do that, I've teamed up with MedSchoolCoach to create this series where I'm going to do a deep dive on each medical specialty. And I want to start off by saying that it can be really difficult to accumulate the number of shadowing hours you really need to be accepted into medical school. And especially nowadays, this can be really challenging. A lot of physicians aren't open to shadowing opportunities in person the way that they were before. So that is why MedSchoolCoach decided to collaborate with over 20 doctors to give you a behind-the-scenes look at practically every specialty that you might be interested in. And this is all completely free. You can go to shadowing.medschoolcoach.com, register for the program, and then you get to choose whichever specialties you're interested in to shadow. At the end, you can fill out a short quiz, and then they'll give you a certificate of completion. That way you can count these hours on your medical school application.
All right, so we're going to talk today, spend about a half an hour, starting off with why vascular surgery. And I'm going to talk to everybody about, what it's all about to be a vascular surgeon and what vascular surgeons do. And then we're going to actually present a couple of my cases, a couple of interesting cases, things that I've been thinking about, professionally for 40 years, things that I'm excited about, that I like, that get me up, that used to get me up every day. Can't wait to get to work. And that's just a great feeling to have in one's career. So off we go. So we're going to talk today a lot about blood vessels. And blood vessels, as everybody knows, are the pipes that go throughout our body that blood is pumped through. And it all starts at the left side of the heart. They go out through the red blood vessels, obviously, which are the arteries. And they are then connected through a capillary bed to the blue blood vessels or the veins, and then the blood is returned through the veins back to the right side of the heart. And in the middle there, where the capillary bed is, that's where the oxygen unloads off of the red blood cells and nourishes all our tissues. So that's fundamentally what arteries and veins are and what they do. And as I said, they are generally paired. They go together and are often have the same name, but not always have the same name. But the red ones obviously come from the left side of the heart. They go out to the body, in this case, the arm, and then return back through here, back to the right side of the heart. Obviously, blood vessels go everywhere in every part of the body, and vascular surgeons take care of patients with diseases of these blood vessels in every part of the body. And that's why I kind of wanted to show this, that I work all over the body, not just on a knee or just on a hip. I'm all over the place. The only place that you won't find me is in the skull. We don't work on the brain or the blood vessels within the skull. And we also don't work on the two arteries in your heart, the coronary arteries, the right and left coronary artery, and their branches. So that's for vascular, that's for cardiac surgeons, and we're just working on all other blood vessels. So what does a vascular surgeon do? We comprehensively treat patients with diseases of arteries and veins in every part of the body except the heart and brain, which is what I said. The key words in this definition for me are comprehensively, that we do all aspects of treatment, and there are other specialties that treat vascular disease, but only can do certain things. They can't do everything. And vascular surgeons, this is why I like vascular surgery, this is why I really loved it, is we could do everything when it came to taking care of patients with these problems. So again, it also refers to, we talked about patients, we're treating patients, we're not treating diseases, and we're treating them with problems in arteries, veins, and every part of the body. And the three fundamental modalities that we use are, we're doctor, even though we're surgeons, we're physicians, and we can prescribe certain medications. And that is a part of my practice and a part of what I do. But the much larger part of my practice is surgery, or in this case, this is a vascular stent. We're going to show a lot more pictures of this, so not to worry. Vascular stent, and this is called endovascular therapy, or endovascular treatment. We're going to talk about the differences here. So again, I do prescribe medications. It's part of what I do, but I'm a surgeon. And so what I do is I do interventions. I operate on people, or I treat their blood vessels from the inside, which is what endovascular surgery is. It's treating vascular disease from the inside of the blood vessels as opposed to the outside of the vessels. So this is a photo of this is an operative photo of a carotid endarterectomy, and I'm sure Daniel has seen this before. At least I hope he's seen this before. This is the carotid bifurcation. So this is a little incision made in somebody's neck, and this artery here, which is the internal carotid artery, goes up into your brain, and it's the main blood supply for 80% of your brain. You have one on the right and one on the left, but between those two, you're talking about that's your blood supply for your brain. And this patient had a blockage right here, right at this so-called bifurcation, and that's where blockages always occur, is generally at bifurcations of blood vessels. And this patient's already had the cleaning out of it, and the reason I know that is because there's a little vein patch here you can see that's sewn right onto the top of the artery. You see how this is a little lighter in color, doesn't look exactly like this part of the artery. So this is a little vein patch that we sew on at the end after we've cleaned out the blockage, the blocking atherosclerotic plaque. So these are the two worlds that I live in. I live in this world, and I live in this world, and we're going to talk about both of those as we go forward. But before we get to the cases, and we're going to illustrate those two things as we talk about the cases, let's talk about the path to vascular surgery. And the reason I put this slide up is that I live in Delray Beach, Florida, and I haven't seen a scene like this in 3 years. So this does not look like South Florida. So which is why I wanted to put it up for just a change for me. This is an interesting slide. I'll bet Daniel and Sam get a kick out of this. And I came across this as I was preparing this presentation. I actually had never seen it before. And this is like, how do you choose what specialty you go into? So here you are, you're a medical student. And if you can then decide, are you sane or are you crazy? If you're crazy and you have no attention, you have a significant attention span, you should become a psychiatrist. But if you're crazy and you don't have any attention span, you ought to be an emergency medicine physician. On the other hand, if you're sane, you're not crazy, but you work hard and you work very hard, but you're nice and then you somehow maybe get to, well, I don't know, you get it back over here to pediatrics or medicine if you're nice. That's kind of cool. But if your attitude, it doesn't really matter, you don't have much of an attitude, well then, depending on what you want your patient asleep or dead, you either go with the anesthesia pathology. But for me, it's always the same. You're hardworking and your attitude, you're very hardworking, and then you're mean, and then you go into surgery. So this is really, for a couple of laughs here, because it's kind of the stereotypes that one thinks of, but certainly not what I would want my surgeon to be. But so I remind, I want students as they're thinking about medical school and then in medical school to keep an open mind. I certainly did when I was thinking about what I wanted to do, because there's a lot of cool things out there. And I know a lot of people who'll be watching this video, have already said, I want to be a gastroenterologist, or I want to be a neurologist. I like neuroscience. And that's great. It's great that you have an interest, and I think it shows that you've kind of been paying attention on your shadowing experiences and all. But most people who say that before medical school don't end up doing what they said they were going in, because they just fall in love with something else. So stay calm and always keep an open mind as you're thinking about this stuff. So how do we get to vascular surgery? Here are the years. These are the number of years. So college, 4 years, right? We got that. 4 years of medical school. And this is the traditional path. And I'm going to show you in a minute that we have two paths now to vascular surgery. But this is certainly the path that I took back in the 80s on my journey to becoming a vascular surgeon. 4 years of medical school followed by 5 years of a general surgery residency. And at the end of that time, I had to take my boards in general surgery. And so I became a board certified general surgeon. And I could have gone out and practiced general surgery at that time. But instead, I chose to do a fellowship, which in my case was just a 1-year fellowship, but most these days are 2-year fellowships. And then following that, then you take an additional board exam. And so I then became board certified in vascular surgery. And so I was dual boarded, if you will. General surgery and vascular surgery. Now, in the old days, the vascular boards were what was called an added qualification. It's a little bit of a nuance. Doesn't matter. It's like having 2 boards. And then a lot of research fellowships, or even some time during residency, particularly if you want to go for a competitive fellowship, requires 1 or 2 years in the lab. Just not to check the box, but more because that's what your career is going to be like, and you want to have those kinds of experiences. So I didn't add this up because it's a lot, but I can tell people it goes by quickly, and this should in never way be determinant of what you want to do. Forget the number of years. It doesn't matter. Once you get through it, that's all that counts. That's your career is what counts. This is easy stuff to get through. And, you know, I had a professor, actually, the guy who was my first role model, he used to always say every year at graduation, at our residency graduation, he'd say the same thing. He'd look me in the eye, shake my hand, and he'd say, the days are long and the years are short. And that's true. I mean, that's really, you know, it's like you're at graduation, you feel like, oh, I was just here last year. But in the middle of a day, when you're a general surgery resident and you got to get through the next 12 hours, you really, how am I going to get through the next 12 hours? It's like you can't even figure it out, but you do, and everybody does. So to always keep that in mind, keep the goal in mind. So this is what general surgery training looks like now, modern day training. You can do what I did, which is a traditional program, 5+2, which is 5 years of general surgery, take general surgery boards, and then 2 years of a vascular fellowship with optional research. This is about what, about right now, about 80%, I don't know, 70% of students are doing. This is the pathway that they're taking to vascular surgery. But within the last 10 years or so, there's been the introduction of a so-called integrated pathway, or 0+5. So you'll hear people talking about 5+2 versus 0+5. This is how people in the field talk about it. So this is a combined integrated program now. You don't go to a general surgery residency. You go to a program that's kind of housed within a general surgery residency, but you get treated differently than the general surgery resident. You're in a different track, if you will. And you do lots of general surgery cases, but not nearly as many as the general surgery residents, and not really the really complicated ones, because it doesn't make a lot of sense for you to train to do super complicated GI surgery when you're never going to do that in your practice. Now, when I trained to be a vascular surgeon, there were a lot of surgeons who did in their practice both vascular and general surgery. That was common. Fast forward to now, uncommon. Vascular surgeons really just do vascular surgery. They don't do general surgery. Now, the exception to that would be if you go out into rural America, there's plenty of people, plenty of great surgeons who do both. They do vascular and general because, I mean, if they don't do it, no one's doing it. So, but for the most part, in any major city, you get your vascular surgeons, you have your general surgeons. So no general surgery boards. The whole program here is 5 years. You come out, you're a vascular surgeon, unless you've taken 1 or 2 years of optional research. If you want to be an academic vascular surgeon, that's what you want to do. You want to work at an academic medical center, be a professor of surgery at a medical school. That would be highly recommended to do, because that is part of what you end up doing. As we all know, academic doctors do 3 things, right? Clinical care primarily, research, and teaching, the so-called triple threat. And so you need some training in that. You need to know how to do that. And a lot of people, the good news now is in my day, if you wanted to do the research, you were in the laboratory growing endothelial cells. Now you can do all sorts of unbelievably great clinical research, artificial intelligence kind of research. So there's all sorts of great stuff that you can do now, and you don't have to go, you know, and because if you're not interested in pure basic science, this is another way to go, another pathway. So these are the women going in, and these are the men going in. And although this doesn't seem all that, you know, equal, because if you think about it, medical school's 50-50, right? And it's been that way for a while. Even my class, which is hard to believe, back in 1978, 50% of my class was women. So we had 75% men and 25% women. So for a surgical specialty, this is pretty good. I'm pretty proud of this. And I want it to get better, and it's getting better. It's definitely getting better. But this is actually a pretty, I don't know what this black thing is, ignore that. This is a pretty good number for a surgical specialty. So something that I think vascular surgeons can be quite proud of. So that's the path to vascular surgery. And again, I think the take home is, you've got two pathways. You've got your traditional and your integrated. And it's really, some of it is how much time you want to spend on it. And some of it is how important you really think a general surgical background is. As a vascular surgeon, it's a subspecialty. It's thought of as a subspecialty of general surgery in some ways. And the reason for that is that every day of my practice, I used general surgical principles. My practice was based on general surgical principles that I learned as in 5 years of residency. So it's not like you learn that and then you forget everything and then you become a vascular surgeon. It's all kind of together, and it's, those principles are sort of what guided me throughout my entire career. So let's talk about two cases. These are two common cases. These are typical patients that I took care of every single day. And as I think, as I said before, it was sort of the challenge that there are with these kinds of patients that got me going and got me up early in the morning and kept me at work, late sometimes, but something that I really like to do. Let's talk about the first patient. So this is a 76-year-old man who presents to the emergency room. He's brought in an ambulance with the acute, meaning it just happened, onset of back pain and syncope. And syncope means you fainted. So this, man, 76, all of a sudden back's killing him and he faints. And when he gets to the ER, his blood pressure is 110/60 and his heart rate is 75. So on the one hand, you might say, well, these vital signs are pretty normal, but these vital signs are really misleading. And they are for the following reason. First of all, there aren't a lot of 76-year-old men walking around with a blood pressure of 110/60. Like, I wish that was, I'd like that to be my blood pressure, quite frankly. So this is low for a 76-year-old man. So this guy is hypotensive, even though, this is my wife's blood pressure. But so it's fine for her, but it's not fine for this guy. So he's a little hypotensive. And secondly, his heart rate 75, which, you could say is a tad high for a 76-year-old. But generally, people, as they get older, they get some disease in their in the conduction system of their heart, and their heart rate tends to slow. And so older people have slower heart rates. And a lot of older people are on medications like beta blockers, which artificially slow your heart rate. And so 75 doesn't tell me anything. Like, maybe he is got a very rapid heart rate and it's just being masked. So I can tell Daniel and Sam this, and I don't know, maybe they won't believe me, but if you called me, Daniel, and you said, I'm in the ER with this patient, I would tell you one thing: I'll see you in the OR. We're going directly to the OR. We're not getting any x-rays. We're not getting any tests. All we're going to get is a type and screen so we can get this person's blood type, and we're going to the OR. And if I can be there in 10 minutes, that's when we're going to start this operation. And the reason I know I said that is because this patient has a ruptured abdominal aortic aneurysm. And there's no question about it, and he can't have anything else. So I can make that diagnosis just from this amount of data. Now, this patient here, this is a CAT scan, and this is a slice kind of x-ray. And this here is the patient's aorta, and it's calcified. That's why it's white. It has calcium in the wall. And this is the lumen here, and it has intravenous contrast in it. And so the lumen where the blood goes is bright on the x-ray because it has this so-called, it's not radioactive, but think of it as being radioactive contrast. It kind of lights up on an x-ray. So this is what it's supposed to be. But the problem is, this is also blood, and it's outside of the blood vessel. It ain't supposed to be there. This is a ruptured aneurysm. Now, this is what we want to avoid: two things. We want to avoid two things. One, we want to avoid a ruptured aneurysm. We want to fix them before they rupture. And two, we don't ever want to see this CAT scan, because if you were my resident and showed me this CAT scan, I would be extremely upset, because we should never have even gone to CAT scan. We should have gone directly to the OR. We should have skipped this space. So this is what to avoid. So this patient has a ruptured aneurysm. Let's look at what our aneurysm is. So here's the aorta, largest blood vessel in the body, right? It starts in the heart on the left side. It comes up through the chest. It goes behind the heart. You can't see it here. Comes down into the through the diaphragm, into the abdomen, and then it what we call bifurcates. One branch goes to the right leg, another goes to the left leg. And just for sake of geography here, your belly button is right here at the bifurcation. So just think of, so your aorta here is just above your belly button. That's where your abdominal aorta is. This is normal. This is an aneurysm. You see this? It's a weakening of the wall, and it's bigger than it's supposed to be. So it's supposed to be, you know, 18, it's supposed to be 1.8 centimeters. And this one is probably 5 centimeters, 6 centimeters. Okay, so it's markedly enlarged. And when this gets bigger, according to a law in physics, the tension in the wall increases, and it's related to the radius of the blood vessel. So as the radius of the blood vessel increases, the tension in the wall increases, and it's going to explode. It's going to burst. It's going to rupture. And when that ruptures, if nothing is done, the patient is going to die, because all of their blood is going to go from inside their blood vessel to outside of their blood vessel. So this can, linger on for a while, because what happens is, without getting too technical, the blood leaks in, it kind of tamponades and stops any more bleeding for a while, but it's a very unstable situation and it will not last. So we want to get there within minutes, not hours, and get the patient upstairs to the operating room. So where do we go from here? We've got an aneurysm. We're now not going to talk about the ruptured aneurysm. I just did that one just to be on the dramatic side. But when we have a patient who has an aneurysm that measures 5 centimeters, that's when we want to fix it. So that is what we call the cutoff point or the trigger point. And that sort of was the guiding principle that I used for my entire career, so that any patient who came to me who had an aneurysm that was 5 centimeters or larger, I would say, you need to have this repaired, because we don't want to be in a situation where you rupture it. Now, aneurysms themselves do not cause any symptoms for the most part. They do not cause any symptoms. So they're picked up on a variety of different ways, usually either on a physical examination by a very good family doctor, or on a CAT scan being done, or an ultrasound being done for some other reason. So somebody thinks they have a kidney stone. In fact, they do have a kidney stone. They go and they get an ultrasound. And in the course of the examination, the ultrasound tech looks at the aorta, just because why not? And they see, oh my God, you've got an abdominal aortic aneurysm. So that's typically how they're diagnosed. Now I want to spend just 2 minutes on this slide. I want you to see this guy here, Juan Perotti. So Juan Perotti used to live in, he's an Argentinian surgeon, an Argentinian vascular surgeon. And in 1990, 1992, he transformed how we think about treating aortic aneurysm. This is so-called disruptive technology. So in my world, Juan Perotti is Steve Jobs. In my world, Juan Perotti is Amazon or Netflix. These are disruptive technologies, right? It changed the way we do things and the way we think about things. And one little quick story about Juan Perotti. So Juan Perotti was a young surgeon. And in those days in Argentina, he did both general and vascular surgery. He was a very young surgeon. Got called to the emergency room one night, and there was a priest there, and his name was Father Bergoglio. And Father Bergoglio had gangrenous cholecystitis, which meant he had a really badly infected gallbladder. Basically, his gallbladder was dead. And without an emergency cholecystectomy or removal of the gallbladder, Father Bergoglio was going to die. So Juan Perotti takes him to the operating room, takes out his gallbladder, and Father Bergoglio survives. Well, guess what? Fast forward, Father Bergoglio is Pope Francis. So if that isn't an amazing story, he saved the Pope's life and he completely disrupted vascular surgery. One guy, Juan Ferrari.
Wow.
Amazing story. So whether or not you fix an aneurysm, either with an open operation or with an endovascular stent, like Juan Perotti taught us how to do, it really is whether or not you like Manning. It sometimes comes down to personal taste. It really comes down to, what are you comfortable with? Do you like Manning or do you like Brady? And, they're both great and they both get the job done. And I think that's really the take-home message. So here's what an open repair looks like. This is how we fix an aneurysm. So we saw that before. Here's the aneurysm. It's right here below what we call the renal arteries. And we put clamps on to stop the blood flow, because you can't open an artery unless you've actually clamped it off. We open it up longitudinally like this and lay it open like a book. And then we sew open this Dacron graft. And it's just made out of Dacron, just like your shirt, no different than your shirt. And it's a tube, and we sew it right into the end here. And here's another little story. I love this one. So this Dacron graft, the first time that it was introduced to be used as a substitute for an artery, it had never been done before, an artificial material substituted for an artery. The first person to ever do it was a Dr. Arthur Voorhees, Dr. Voorhees. And remember I told you that story about that carotid endarterectomy I saw as a second-year student? Guess who did it? Arthur Voorhees. So I've had a pretty amazing experience. Wow. I actually get a little emotional just talking about it. But anyway, here's the Dacron graft finishing up this repair. This is a great operation. This goes into the Hall of Fame of operations because it's fun to do. It works, like it really works. But the downside is it's an enormous operation for the patient. It is really huge. It's, in some ways huger than having open heart surgery. It's more of an insult on somebody's body. So it's the plus and the minus. It really works. It gets the job done. And it's durable. It lasts forever. You put this in, you're done. That's it. You don't have to worry about it again. Here's another way to do it. So this is called an endograft, and this is what we learned from Juan Perotti, and it's been advanced now multiple times in multiple different iterations. So this is called an endograft, and it's introduced from within the blood vessel. And we use the femoral artery for access. So we put a needle in the femoral artery, put a wire, catheter, get access, put our catheter up into the aorta. See, here's the aneurysm. See the purple? This is the aneurysm. And we insert this big thing. We squish it up onto a catheter, crinkle it up, and push it up into the aorta, and then let it go and expand it. And it lands right here and sits right inside the aorta like this. And it actually comes in two pieces. This is the main body, and this is the limb extension. And you bring this one up through the left side. This goes up through the right. This goes up through the left. And inside the body, inside the artery, you attach these two. You attach that to that. You put it right into it. And if somebody had told me when I was your age that you'd be able to do something like this, I'd say, no way. I mean, come on, no way. But we do it, we've done it, and we've been doing it for many years now. So this is an endovascular treatment. So this is what it looks like, right? We're going up the right side with a wire here. We put our graft in place, we just expand it, and then it sits right within inside the aneurysm. You never open the aneurysm, it's all done from inside. It's called an endovascular stent graft. Here it is again, just give you a bigger picture of it sitting inside the aorta. You see it's modular. It comes in multiple pieces and you attach them inside the body. And it's kind of cool. So for people who like video games and like to look at a screen and do something with their hands, it's pretty awesome. So here's the final product. So here's a patient. This is an angiogram, and here's right here is the aortic aneurysm, right? These are the renal arteries, and the aorta should only be this big, but instead it's this big. See how huge it is? It's a large aneurysm. And this was fixed with an endograft, and here's the endograft in place. So now when you put the dye up here and inject it, it only goes through the endograft, and you don't see the aneurysm because the dye's not going in the aneurysm. It's staying in the endograft. back in the late 90s, around the year 2000, which is when, it really started to catch on. We didn't know. And so we only did it in really old people. And then as we followed those really old people, if they lived, we found, hey, wait a minute, this lasts. So we only did it in 90-year-olds. Then we said, okay, now we're going to do it in 80-year-olds. Oh, it's still working. And we started doing it in everybody. So now we do it in everybody, and it does last. Now, it does have you do sometimes have to go back and fix it up a little bit. But again, not usually with an operation, but with some kind of minimally invasive procedure. So it's not a permanent solution like an open one, but it's probably, got enough upside to accept that kind of a downside. Because somebody who has this operation goes home the next day from the hospital. One night stand, that's it. And the operation can be done under local anesthesia. Whereas an open operation, 7 to 10 days in the hospital. That's disruptive technology.